Well, hello. We're going to speak about the second part now that includes that combines Appendix C of the Candel 2013 and Chapter 60, which is language. But we are going to look at the second part of language, which is the aphasias, and then we combine that with the cerebrovascular disease that affects the brain. So we have some kind of a complementary view looking at how brain damage that results from cerebrovascular accidents leads to aphasia and different kinds of disorders. So let's begin. So aphasia is a language disorder that is caused by some kind of cerebrovascular accident in the brain. Cerebro means brain, so cerebrovascular accident. When we look at the blood supply and how it is structured, just think about a tree. As you go from the trunk, the branches become smaller and smaller and smaller until you come to a very small branch. So when we spoke about aphasias and the two kinds of cerebrovascular accidents that can cause it, we spoke about hemorrhagic stroke, and we spoke about occlusive strokes that result from either a thrombus or an embolus, basically some kind of occlusion or a blood clot that blocks off an artery in the brain. And as a result, the area that is supplied by that artery goes into cell death, and we have the area that the cells die in, the neurons die in, is called an infarction or infarct. And the area around it is called the penumbra, which is an area that has decreased blood supply, and it is vulnerable. And if you don't save the patient immediately within hours, that area in the penumbra can change into another infarction where the tissue is going to die. So it depending on what area of the brain has the stroke or the cerebrovascular accident. That is the way it is related is going to affect the symptoms. It will produce particular symptoms. For example, if you have the damage in Broca's area and the complex around it, that's going to produce a specific set of symptoms that is associated specifically with damage in that area. If you have, say, the stroke in the back here in the occipital cortex and areas around it, that's going to lead to visual problems. So again, the location of the stroke, if it is right hemisphere, left hemisphere, and so on, that's going to determine what kind of symptomology you are going to get. So Broca's aphasia results from damage to the area that is known as Broca's area or Brodmann area 44 and 45, and the areas associated with it. So if the damage is specific to Broca's area 44 and 45, that is going to be mild. It is likely that the patient will recover from that. However, if the damage involves parts of the network, that is the Broca's area network, that is going to lead to significant deficits, and the recovery from it is going to be very difficult. So true Broca's aphasia is that kind when you have Broca's area damaged in addition to some of the other areas that are part of the network. This area, this complex, the Broca's area network, it is involved in assembling sounds into, syllables. Like you get the phonemes together, combine them to make a syllable. And then that is whether you are going to say the syllable or you are going to hear it. So in either way, this complex is specialized in assembling the sounds into words, and then assembling the words into sentences, and also it enables us to produce speech, to verbally say sounds and words, and to also coordinate and sequence sounds so that when you say, put them in a word, that they come accurately, they make an accurate word. So again, this complex is responsible for the grammatical assembly and phonemic assembly, in addition to motor production for speech. So Broca's area complex, or Broca's area network, again, the center of it is Broca's area, Brodmann area number 44 and 45. However, we also include in that network Brodmann area number 6, number 8, 9, 10, 46. If you look at the frontal cortex, that basically the whole frontal lobe is covered by these areas because they're extensive areas. So when you say area, Brodmann area 6 and 8 and 9 and 10 and 46, again, it is most of the frontal cortex in front of the primary motor cortex. In addition, all the white matter beneath, because these cerebral areas, area 6, 7, and so on, they have the cell bodies and they send down the axons. So if you have damage in the cell body, then that is definitely going to lead to damage in the axons. So the white matter beneath, which is made out of all the axons, and the left hemisphere insula, because we are speaking now about Broca's area being specific to the left hemisphere. Do not make the mistake and think it is either, it is only found when you say Broca's area, it is only localized in the left hemisphere for the majority, the overwhelming majority of people. Then we have also the left hemisphere insula, which, as you know, is buried underneath Broca's area and under the opercula, which opercula, which are part of the corner of the frontal lobe, the corner of the parietal lobe, and the corner of the temporal lobe. So if you just uncover that, you will find that island buried underneath, and it is is connected to Broca's area, and it plays a significant part in production of speech and in forming the intention to speak and so on. We also have the basal ganglia, which are buried deep in the brain, as you know, and a small portion of the anterior superior temporal gyrus. So the temporal gyrus, the temporal cortex, is made out of 3 lobes. The lowest one is the inferior temporal lobe, and then the medial is the medial temporal lobe, which is where the auditory association cortex is, and then the superior temporal lobe. So when we speak about the posterior end of the temporal lobe, then we speak about Wernicke's area. When we speak about the medial area of the superior temporal cortex, gyrus, I should have been saying gyrus, the superior temporal gyrus, this middle area of it is area 41 and 42. You know this as the primary auditory cortex, which is the head or the tip of the transverse gyri of Heschel that go down, in a transverse way, and they their head, the tips of their heads is what you see. And So that's the primary auditory cortex. And then the area, when we say the portion of the anterior superior temporal gyrus, we speak about the frontal piece of the superior temporal gyrus, the anterior segment of the superior temporal gyrus. Again, all of these areas are the areas of the left hemisphere, because we are speaking about Broca's and the areas associated with it. So we are specifically speaking about the left hemisphere. So if the damage includes the left hemisphere insula, the patient will have difficulty making sounds. So you can understand now that the insular cortex, or the insula, contributes to the motor production of speech. And also, particularly, the insula is responsible for, or contributes to, the assembly of sounds in the sequence that you want to say them. So if there's a problem, of course, you are not going to be able to put, say, when you say cat, you would have difficulty saying ka, and then and then ta. So the insula contributes to this function. And if there is damage, that is going to cause problems in sequencing of these sounds and also pronouncing them. So the insula is responsible for coordination of the articulatory movements for speech. The diagnostic features of Broca's area. First, you have to keep in mind that among patients, there are different levels of severity. There is a slight, mild, moderate, severe, and so on. And in any disorder, you'll find these levels. So when we speak about the symptoms and all of this, it is, you are going to find some common features among patients, but it isn't like every patient is exactly similar. So people present in different ways, even though there are some common broad symptoms. So number one, because Broca's area and the complex around it are responsible for assembling speech into words and sentences, and producing that motorically, making the script to speak, and then giving the order for these sounds to be produced as intended. And then also sequencing putting the words in the right grammatical order and sequence, and using and selecting the right words and saying them in sequence, and so on. So that, because the damage occurs through this complex, then you have these symptoms as a result. Number one, impaired grammatical processing. The person will have difficulty producing sentences. Mostly, they will have, their output will consist of nouns and verbs, and the words that describe nouns and verbs, which are adverbs and adjectives. And then they tend to leave out grammatical words like prepositions, conjunctions, and grammatical words. So again, you will find some people who are able to use some of these words, but typically they are the majority, they are significantly disabled in the area of using grammatical words. Because of the motor involvement, and because this network is responsible for producing or programming for speech production, then the person will have difficulty with the motor production of speech. They will speak slowly, and their speech is labored, and they will have poor coordination of articulation, and also they will have decreased fluency, which means they might pause, they might try to remember words, and they just can't get them out, so they pause, and they give you words like, like, so they give you some gap fillers, and until they can get out. Sometimes they might not be able to get the word, so they have word retrieval problems, but if they use a pen, they can write it down, and then they can read what they wrote. they also impaired melody, impaired intonation of speech. And we said that the production for melody is usually in the area across, the mirror area across from Broca's area in the right hemisphere. So that means that there is somehow some kind of connection between that area and the left hemisphere, and as a result of the network damage damage to the network that includes Broca's area, then the person will not be able to like raise pitch and lower pitch and have that kind of nice active way of speaking. Instead, they will have monotonous speech. Difficulty repeating complex sentences. What is known in most the research, they will use repetition as a measurement, as a way to evaluate the aphasias. Is the patient able to repeat what someone else says? So traditionally, they would tell you, oh, Broca's area, they can repeat. But if you have a sentence that is grammatically complex, they will have difficulty repeating that. So, and the new view, the modern view of Broca's area, Broca's aphasia is that it affects both expression of speech, using in a speech and grammar and so on, and comprehension. Because when you comprehend in grammar as well. If the grammar is not accessible to you, then you would have difficulty understanding the meaning. So if you have, for example, a syntactically ambiguous sentence, that is going to cause the person will not be able to understand. So for example, if you say, the girl ate the fish that the man caught, or if you just switch into a passive form, like the fish that the man caught was eaten by the girl, that will completely throw them off, because you switched. And the traditional sentence form, the declarative, is what we are used to. But if you switch to the passive form, that is going to give them a form that's going to challenge them. So it affects primarily expressive use of grammar and the actual pronunciation of the words and the production of the sentences and so on, in addition to the comprehension. They also will have fragmented comprehension as a result of the grammatical component that is associated or that facilitates your ability to comprehend speech. There are 3 videos here. They are by the same patient. She had her stroke at age 19, I think, 19. And then, as you watch this and you can see the symptoms, how they develop, to let you know the aphasias are, what is common among them is that they are non-progressive, that someone has them and they start to have the symptoms, they improve a little bit, and then they kind of tend to stabilize. With treatment, of course, you can improve a lot, but they don't progress. They do not become worse over time if they do not become better. There are 2 kinds that we're going to speak about later that are non-typical and that are part of dementia. So pay attention to these. So this video by Sarah, I forgot her last name, she's from Britain, and you could see the symptoms. And then you go and watch the next one, which is 16 months later, and you can see, of course, you have to pay attention to the background, because there's the initial one, the background is dim and she doesn't look as presentable and so on, and that gives you the impression, oh, the symptoms are bad. And then when you watch the second one, she's all nicely groomed and the lighting is great. And then when you see it immediately before you start listening to her, you think that the symptoms have improved a great deal. But I'll leave you to judge and to tell me what you think, how much of improvement there is between the first and the second one, and how much of a difference has she accomplished over 6-7 years. So because the last video is 7 years later. So how much, in your estimate, how much has she made of an improvement, for example, compared to the initial video? Wernicke's area, as you know, again, and the temporal cortex, the superior temporal gyrus, the posterior segment of the superior temporal gyrus, area number 22, Brodmann. And then it isn't, the traditional way to look at that, Wernicke's aphasia, is to say Wernicke's area is damaged. But that is not the view anymore. Wernicke's area is a center where that is at the corner, between the temporal cortex, the occipital, and the parietal. So it comes at a junction between auditory areas, or among auditory areas, visual areas, and tactile sensory areas. So the areas around it and the posterior area of the temporal lobe itself, and where the three lobes meet, parietal, visual, and temporal, then that area, when it is damaged, then you have symptoms of Wernicke's area. So Wernicke's area, again, is part of a network that associates speech sounds with the concepts. For example, you get the sounds when you hear a word, say cat, ka, t. It comes to you like this. One sound, one sound, one sound. Because of the air vibrations, the air wave are going to come in one sound at a time. And then you kind of start to, in the primary auditory cortex, takes these sounds, and then it is, of course, connected to Wernicke's area. And then they work together to assemble these into a whole word, cat. And then what does that mean? What is cat? Now, we don't have the linguistic meaning at that time. And then another area, the auditory association cortex, which is in the temporal cortex lobe, and the medial, behind it is the memory center, the hippocampus. And working together as part of the network, now you get the meaning. What does cat mean? And then that meaning is accessed, and it is sent to Wernicke's area, and then it's assembled. You have the word cat, and then you have the meaning of cat, and other areas in the visual cortex and in the temporal parietal now give you the image of the cat, give you the texture. What does it feel like when you touch a cat? What does the sound like? And so on. Whatever connects as part of the concept to the word cat and connects with it, then all of that is integrated. And then that information is shared with Broca's area, and then they keep communicating back and forth, and depending on the activity that you do, if you are writing or speaking or whatever, or hearing the word and comprehending it, you put it in the right place and you start to process it based on the context. So another function for the Wernicke area network is attention. It contributes to attention, and especially attention mostly is in the prefrontal cortex and in the parietal cortex. There are pathways that connect them, and they are central for building your intelligence. So, and the area is responsible for storage and processing of the meaning of concepts. Remember that when we spoke about the Damasio model of language, around the temporal fissure, the areas around it and the three lobes, these are the central areas we know as the language implementation areas. Then around them, there's like a belt that goes from the lower half of the temporal cortex, and then the frontal, the prefrontal cortex, and then parts of the parietal lobe. All of these areas together around, they make like a belt, and these areas are the areas that link your language with your concepts. So that is the mediational, and then you have the conceptual area that has all, different knowledge of concepts and so on. So just to recall, go back to the Damasio and Damasio model of language. So the areas that are responsible for storage and processing of meaning of concepts include the frontal lobe, the hippocampus, the visual cortex. Recall that the hippocampus is central in facilitating the recall, in facilitating also the storage. So when you want to say something, you want to recall it, it has to go first to the hippocampus. When you want to store it, it's coming in and you want to store it, the hippocampus activates it. The hippocampus doesn't store concepts, it processes them, organizes, sequences, and facilitates storage, consolidation, and recall. So this is why it is added here, because it facilitates the other. But the frontal lobe and the visual and other areas they have areas of the cortex that actually store. They are storage sites for the information. So that is an extensive network. And remember that Wernicke's area is connected with Broca's using the arcuate fasciculus. And I told you that the arcuate fasciculus is not just a pathway, a directional pathway that connects Wernicke's to Broca's. It is a massive pathway that connects, through this connection, it connects the temporal cortex with the parietal cortex, the visual, and also the frontal. Because if you say, I am going to connect Wernicke's to Broca's, and you know that Broca's is a center of an entire network that includes the entire frontal lobe, then it means if there's a connection between Wernicke's and Broca's, naturally that connection is going to be between Wernicke's and the entire frontal cortex. The same way, if we know that the Wernicke's area is part of a whole network that includes all of the other areas around it, a connection to it is going to facilitate basically communication with all the parts of the network. So the damage to the left posterior temporal cortex, and that again includes Wernicke's in it, but it includes a whole area surrounding Wernicke's. It damage to the left auditory association cortex, Brodmann area number 22. Actually, Wernicke's is number 21. And severe and persistent cases of also involve damage to the middle temporal gyrus here and the white matter beneath it. There are two videos here of patients that have Wernicke's area. I would like you to listen to both of them and take notes, understand the characteristics. Ask yourself, why is this person's language different? What makes it, what are the characteristics of the way that this person speaks, and how is this different than the language of a person who doesn't have, say, a cognitive or an aphasia, basically. How is that different? In other words, a neurotypical. So take these because they are important. They will make you understand what it looks like, what Wernicke's aphasia looks like when you see it in a patient or when you see its characteristics. Wernicke's aphasia, the diagnostic features, number one, the person, yes, is fluent. They produce speech effortlessly. or they produce more, they are able to make motor movements for speech, and they have a normal rate of speaking and normal intonation. However, in some cases, you cannot understand much of what they say. And the reason is they have all, problems putting words in the right sequence and the sounds in the right sequence, making, semantic errors in addition to phonemic errors. We call these paraphasias. So, frequent phonemic and semantic paraphasias. Phonemic paraphasias, for example, involve substituting one sound for another. Like you want to say cat, it might come out as a calf, or cat, it might come out as laugh. So it depends if there's one single sound or two sounds interchanged, or one sound is substituted for a totally different sound, or more sounds in the word are. And you will listen to the two patients and you will find examples. So it will be important to take examples of what they say and make them, you can use them for exams or as examples for clinical purposes. Semantic paraphasias involve using the wrong word. For example, you want to say president. You might say, the headman. The headman calling the president. So that is a paraphasia, semantic paraphasia, because you did not use the word that actually describes a president, for example. So also the person will have difficulty monitoring their own speech. As they speak, they think they are making completely common sense, but their speech is not making any sense at all. As you see in the lady, as she is, trying to say. And there is in some cases, something called press of speech. Press of speech means that the person tends to keep talking and talking and talking and talking, and they have difficulty stopping themselves, even though they are not making sense to you as a listener at all. They have difficulty comprehending other people's speech. So because, again, the whole area of auditory comprehension is affected. And I want to say that the traditional view of Wernicke's area it is, primarily an aphasia that affects auditory comprehension and comprehending and listening and so on. But yes, it is true today. However, it is beyond that. Wernicke's aphasia affects verbal production as well. The reason is, before you say something, your brain, unconsciously, is going to make a script. So it takes your thoughts and it assembles them into language, and it uses Wernicke's area to listen to that language and say, what does it sound like? Is it making sense? And then send it to Broca and say, how am I going to say these words? And so on. So as a result, if someone has a problem, has a Wernicke's aphasia, yes, they will have primarily comprehension difficulties and speech production difficulties. However, they will also have difficulty with expression of meaning itself. Conduction aphasia is a combination of both Broca's and Wernicke's aphasia. It is caused by the damage to the network, for example, that is needed or that is specialized in assembling phonemes into words and in coordination of speech sound production. When we said coordination, go back to the insular cortex and its connections. And when we say assembling phonemes, then you go back also to the superior temporal gyrus, the auditory cortex and Wernicke's and the areas associated with it. So damage to this, the damage to these areas here that involve both frontal and posterior destroys the feed forward and feedback projections that interconnect areas of the temporal, parietal, insular, and frontal cortex. A big part of that pathway is the arcade fasciculus. So, these areas, if they are affected, the back and forth information going forward, exchange among these lobes is going to be disrupted, and as a result, the person will have symptoms of conduction aphasia. So the damage involves the left superior temporal gyrus, and Brodmann areas 39 and 40, which are near of the left inferior parietal lobe. So also the damage may also extend to the primary auditory cortex, areas 41 and 42. It might include the insula, and it also might include the underlying white matter of these areas altogether. The clinical features or the diagnostic features of conduction aphasia include difficulty repeating sentences, difficulty assembling phonemes into words, again, because the areas of the temporal cortex are affected. Verbal production includes multiple phonemic paraphasias, just like Wernicke's, and difficulty in naming pictures and objects. So that is a combination of both frontal and temporal problems. And the speech production and comprehension, both, particular, components of Broca's aphasia and comprehension parts of Broca, Wernicke's, they are not as significant as those that are associated with Broca's and Wernicke's. However, they are a combination, of course, and the patient is able to comprehend simple sentences and to produce speech that is generally intelligible. Then we have global aphasia. From the name, you could see that it's affecting a wider area. Features of global aphasia combine features of Broca's, Wernicke's, and conduction aphasias. It results from the damage to multiple regions involved in the language comprehension or reception and language production, verbal production or written. It can only be caused by cerebrovascular damage to the areas supplied by the middle cerebral artery. Do you know why? Go back and look at the map, and you will find that the language implementation area and the huge belt around it, the mediational area that connects the language implementation with the conceptual, these areas, it's an extensive area that is supplied by the middle cerebral artery. As a result of damage in that area, it will hit hard in all these, in the language complex. So global aphasia lesions involve anterior language regions of the basal ganglia and the insula. So we are going deeper, into the brain, and also on the cortex itself. So damage to the auditory areas of the cortex, primarily auditory cortex and auditory association cortex. Now you cannot integrate sounds and you cannot get the meaning associated with sounds. Damage to the posterior language regions, Wernicke's areas, and the areas surrounding it. Excuse me. So now you cannot, again, associate meaning with the words. So the diagnostic features include difficulty comprehending and formulating language, difficulty repeating sentences, severely decreased speech output with limited, speech is limited because of the extent of the damage, and the person would just be only limited to a few words. And the person might try in vain, to basically express himself or herself, but they have these few words they keep using over and over. Procedural or automatic speech forms, for example, swearing, counting, saying the days of the week, things that are automatically you don't think about, they are preserved. So also familiar songs are preserved. So there are severe comprehension difficulties, with comprehension being limited to a few words and some idiomatic expressions. Idiomatic expressions are things people use over and over, and they just like routine, almost like the procedural forms of language. So these are forms that you don't need to think about. Then we have transcortical. From what it says, cortex, and then transcortical is across different areas of the cortex. And there is transcortical motor aphasia and transcortical sensory aphasia. Both of them result from damage to areas that are near Broca's and Wernicke's, and also the pathway that connects these connects them to other areas, especially the arcuate fasciculus. So the damage, the damage does not involve the arcuate fasciculus, but involves the pathways that connect Broca's to other areas and Wernicke's to other areas. Now, when we look at them individually, transcortical motor aphasia is going to be characterized by difficulty in speech production, physical articulation, physical production of speech. It results from damage to several structures, including the left dorsolateral frontal cortex. In the frontal cortex here, and dorso is almost like going up higher, and lateral, so it will be near here, just about near here. It's part of the prefrontal cortex. In that particular location of the left dorsolateral frontal cortex, you are going to find the frontal association cortex that integrates information, where it makes connections with other parts of the brain, especially the parietal cortex. And association cortices, as you know, connect different regions, large regions of the brain together. So that damage there is going to cause significant impairment. And also Broca's area itself is affected. So it can be also, this aphasia can be also caused by damage to the supplementary motor area. The diagnostic features include impairment in the fluency of speech. When we say speech fluency, that means the person is going to produce adequate speech, flowing, saying the words and moving on, pausing correctly when they are supposed to pause, and so on. If that is disrupted by saying, for example, you want to say something, say or pausing, or putting things like, all of these are disfluencies. So the speech is going to be labored. And the person will also have, at the same time, the ability to repeat sentences. The person will have difficulty producing names or actions. It means nouns and verbs. For example, if you show them a ball and say, "What do you do with the ball?" They would say, the person would say, "I'm supposed to say kick it," but they would not be able to say that, kick it or throw it. Sensory aphasia, transcortical sensory, TSA, primarily is a deficit in semantic retrieval. Retrieving the meaning of words without significant disruption of syntax or phonological abilities. So semantics. It is caused by damage to parts of the conjunction of the temporal, parietal, and occipital lobes, and this junction basically. These are where the operculi are, where the operculum, the three operculi are, opercula, actually. So the region that connects the language areas around the temporal fissure and with the areas of the brain that control meaning of concepts. So when you say sensory aphasia, it means it doesn't involve motor. It is just involves thinking about the meaning, which is more of a sensory task. So the symptoms include fluent speech, impaired comprehension, and severe difficulty with naming pictures and objects. That is part of semantics. And the person is able to repeat things. And then we have the kind of the atypical kind, which is the primarily progressive or primary progressive aphasias. These are two kinds. They are a kind of dementia. They are progressive non-fluent aphasia and semantic dementia. So again, they are atypical because they progress, they become worse. Symptoms become worse over time. So the basic diagnostic features include language deficits that progressively become worse, progressive cognitive decline, and gradual loss of the day-to-day living skills until the person is no longer able to perform these tasks. This is similar to Alzheimer's. Alzheimer's is a kind of dementia as well. Sometimes it was called senile dementia. So now I would like you to understand all these aphasias, what each one is like, what causes it, what areas are damaged that produce these symptoms. And I'd like you to know the diagnostic features that characterize each one of these aphasias, and hopefully connect these to what we have studied regarding cerebrovascular events and that cause aphasias. Thank you.